you all for joining us, and thank you particularly to Dr. Nicola Brimblecombe, who is here today to speak about care in place, older people's housing and communities and their social care needs, care use and care costs. And I'm sure all of you know who Nicola Brimblecombe is, but just for a bit of background, she is the Assistant Professorial Research Fellow at CPEC, which is the Care Policy and Evaluation Centre at the London School of Economics and Political Science, the LSE. And I'm sure you're all aware of her enormous research background related to unpaid carers, young carers, housing and care, unmet need, inequalities in care. And she's got some really fascinating projects on the go looking at housing, which this speaks to, but also integrated support for unpaid carers and young carers and whole family approaches as well. So strong alignment with all the interests we have in the room today. So what we'll do is we'll invite Nicola to speak and share her presentation. There is a chat function, so you can add questions as you go if you don't want to hold on till the end. But then there'll be plenty of time at the end for a discussion and a conversation where you can raise and ask your own questions, or I can read them if you'd rather from the chat. So without further ado, I'll hand over to Nick.
Thank you very much for that introduction. As Kate said, my background's in unpaid care and also in the wider context of care and inequalities in care. And this is very much where this work sits. So I'm going to mainly talk about our work on housing and social care, and then towards the end introduce our new study, which is widening it out to look at more broadly where people live, their neighbourhood. So apologies to some of you who have heard bits of this before, but this is kind of presenting the whole project. So the team is myself and the people mentioned here, also at CPEC. And this is, as I say, an overview of this project that looked at older people's housing and their care needs. So next slide, thanks. So a bit of background. So housing characteristics. Housing is considered a really important part of the delivery of care. It's in the Care Act. It's the integrated care systems and the Better Care Fund and all the stuff around integrated care is talking about the integration of health and social care, but also housing. And then the Adult Social Care White Paper that came out in 2021, which is the kind of mission statement for adult social care, says to make every decision about care a decision about housing. Around the same time, an older people's housing task force was set up and has now reported. So supported housing is considered, and sheltered housing, extra care housing is considered a very important part of this, not as maybe as important a part as the developers are hoping for. It was quite influenced in the housing task force, but the vast majority, as well over 80% of older people, by which we mean 65 and older, live and will live in non-specialist housing. We couldn't even build enough supported housing, even if that was people's choice. So this study very much focuses on this non-specialist housing. So next slide, thanks. So the project has kind of had two overarching aims, although the project has finished, it's feeding into the Casey Commission and still quite a lot of outcomes and impact from it. So we wanted to look at the relationship between the characteristics and conditions of non-specialist housing and older people's care needs, care use, both formal and unpaid, and the care costs. And as a sort of practice aim, we wanted to understand how to improve housing, to reduce care needs, optimise care use, which, as you'll see later, might be increasing it for some people and preventing the need for it for others, and sort of to enable more choice in people's care situation and housing situation. So the methods are analysis of several waves of the English longitudinal study of ageing, which, if you don't know it, is a representative sample of people aged 50 or 55 and older in England, and it's household, so it's people and the carers who they live with. and our sample was about 8,000 for this analysis. We did in-depth interviews with 72 people aged 65 and older with care needs, or sometimes their carers in 5 different areas in England, and some simulation modelling, both for the costs, but also to look at if we were to improve housing, how would that affect the costs? Next slide, thanks. So firstly, I'd like to talk about housing and care needs. Next slide, thanks. So this is the ELSA, the survey data. So for most people, they don't just have, so ELSA has information about 13 different types of housing issues. So there are things like damp, cold, condensation, vermin, roof issues and structural issues and so on. And it also has lots of information on care needs. And we can look at housing problems at time one and what happens to care needs and care use subsequently. So it's very useful data for us. So, but people didn't tend to just have one housing problem. They're all interrelated. So having a higher number of problems in the accommodation led to a higher probability of having care needs at all, a younger age of onset of care needs, which either potentially means more years with disability, or it might mean earlier death, and a more steep increase in care needs over time, having got them. So it affects care needs very strongly. So in terms of the median age of onset, so people without housing problems, this is survival model, so it doesn't take into account all the other things that might influence somebody having care needs. But we also have done other analysis controlling for a whole lot of factors that also affect people having care needs, and the relationship still holds. But people without housing problems, the mean age of onset, age of onset of care needs is 90 years. And you can see even with one housing problem, that's 9 years previously. It's about 21% more likely to have a younger age of onset, controlling for a whole host of other things if you've got housing problems. The next slide, please. So this is number of housing problems. Most of on their own, if you look at individual housing problems, the most important ones are condensation, linked to sort of things like roof and damp, and fuel poverty. Again, if you've got issues with cold and damp in your home, you're more likely to have care needs, to have a higher number, younger age of onset, and for these care needs to increase more steeply over time, which has a lot of implications both for the individual and for the carers. Next slide, thanks. So in the interviews, the factors most associated with care needs, cold and damp, came up again. Cleanliness and repairs often linked to cold and damp, windows, roofs, access into around the home, space, the amount of space in the home, but also the configuration of the space, and housing tenure. I'm just going to talk about two of them. Yeah, two of them today, but and then move on to talk about care use. So the next slide, thank you. This is kind of illustrative. It's a two-way relationship. So having care needs, so it sort of exacerbates, having care needs exacerbates it. So it might either cause the care need and then kind of make it kind of worse in terms of cold and damp, or the other way around. So having care needs often means a greater need for heating. So this is just one quote. We're paying a lot of money for it because of the medication she's on with blood thinning and all. We have to have the house heated. So I dread to think how much it's costing us. We keep getting told by our supplier to increase our standing monthly order, so they were really worried about it. And then, but difficulties leading the home could lead to or exacerbate care needs. In fact, it is one of the leading causes of falls, being cold in the home. And this is an example. This person had quite a lot of falls. We've cut down massively. We only have it on for about 2 hours a day, an hour in the morning and an hour at night. I tend to get kind of stiff, and then he'd had several falls. But conversely, in places where it was much cheaper to heat, this was following a move. It's cheaper to run the flat. It doesn't cost as much in heating as the house did. It eased a lot of the stress on us, and that improved his health. So these are the different ways in which cold and damp and fuel poverty affected people's care needs and vice versa. But yes, people with care needs may both have more of a need for heating and less ability to pay for it because of all the other determinants of having care needs. So moving on to repair, and that's the next slide. So again, we saw both how the kind of state of repair and the cleanliness and clutter in the house could either lead to exacerbate care needs, including poor mental health, and vice versa, that it could lead to difficulties in maintaining the home. So I'll just read one of these quotes, but I feel that if the house isn't as I want it, that affects my health. And that in turn, if I feel quite low, then I don't want to do anything about it. I don't want to clean and tidy. So that kind of two-way relationship. So I'll move on now to costs, to care costs. This is from the simulation modelling. That's the next slide, or probably the one after that. So this is we do a lot of work projecting need for care over the next few decades, and this is using that model, that baseline model, but then modeling in housing problems. So as I've just shown, the overall effect for housing problems, number of housing problems, is to increase care need. And these are the associated costs. So the baseline is 2022, just for this data that we've used. By 2027, it'll cost formal care costs for adults so care services aged 65 and older in England will be is projected to be 24.6 billion. If we reduce housing problems to zero, and most people didn't really have more than three or four, that would save 1.13 billion a year. And just removing the excess cold, damp, or condensation is a third of a billion, whatever that is in millions. And this doesn't take into account the cost of housing improvements, but some of these, particularly around cold, damp, or condensation, will be much lower than this. And these are yearly costs, and a housing intervention improvement might be a one-off cost, or certainly not every year. So, and this sort of increases over time. And then the next slide looks at a number of carers. So we project that there will be what is that, 2.2 million carers of people in it aged 65 and older in England in 2027. If we reduce housing problems to zero, we'll need 100,000 less carers. So that is a significant difference in terms of the number of people that may need to provide unpaid care. And again, these are year on year. So, and the figures for excess cold, damp, and condensation are there. So, housing problems have an impact on carers as well, as you can see from this, and improving housing would also support family carers. So, I'm now going to turn to housing and care use, which So in our study, we see two different pathways by which housing is linked to people's use of both formal and unpaid care. So as I've just talked about, poor quality and unsuitable housing increases the likelihood of having care needs and a higher number of care needs. So we might therefore expect it to lead to an increase in care use. And that's certainly the overall picture, as you will have just seen from the costs. But also, as we know from a lot of other research, having care needs is certainly no guarantee of having them met. And poor housing is also a barrier to care use. And again, we know that the barriers to receiving care are to do with systems as well as individual and household factors. And sometimes both of these things happened. Next slide, please. So this is, we did some structural equation modeling to look at those two different pathways. And this is a slide I really like presenting because it kind of demonstrates everything about care use in one slide to me. So at the top, the total effect is that number of housing problems does increase care use, not that's the total effect. Oh no, sorry, has no effect, no overall effect, no significant overall effect. That's the total effect. But within that, there's a lot going on and quite a lot of inequalities. So the direct relationship between housing problems and formal care, so various types of care use, various types of care services, is to decrease it. That's the direct relationship, but indirectly it increases care needs, and that in turn increases formal care. So the direct relationship is, all things being equal, if people have the same amount of care needs, having housing problems will decrease formal care. And then the next slide shows the same for unpaid care, but the relationship between housing problems and unpaid care, the direct relationship isn't significant, but much the same thing is going on here. Unpaid housing problems decrease unpaid care, although as I said, it's not statistically significant, and increase it through care needs. So how to explain that? We turn to the interviews to explain this a bit more. And we went back and forth between the interviews and the ELSA data, which is what that modelling, that structural equation modelling just showed. So very, very, very similar factors to care use, cleanliness and repair, access into the home, space, housing tenure, the kind of internal adaptability and familiarity. So I'm going to talk about some of these. So first of all, next slide, thanks. Cleanliness and repair. So the two pathways here. So housing condition, the cleanliness and the lack of cleanliness or clutter in the home did sometimes increase care use. Sometimes it was something like a council mandated decluttering services. Sometimes care workers doing the cleaning in a way that they probably weren't supposed to be, but that did increase the hours that the care workers were there. More often it was a barrier to care use. So if the house isn't safe, obviously the care workers shouldn't be working there. So this was an example. Because her flat was not fit for habitation, the mould on the windows, they were going to put in home help to come and sort you out. This is the carer speaking, but then they weren't allowed in for their health and safety. So this person had a lot of problems in her home, had been living independently, had had a fall, and had to, was temporarily in a care home and couldn't have care come in. So this both increased one type of care use and decreased another one. Next slide, thanks. Access into the home. So lack of access into and out of the home could mean, well, often increased care use, in that somebody needed either an unpaid carer or a care worker to get in and out, including to appointments. One example here from a carer. I think it's so important to give freedom to people. Without a lift, I have to take my dad now to the hospital. Whereas before, the father could have gone by himself with public transport, but couldn't leave his flat without help. But in other ways, it was a barrier to receiving formal care. There's no way I can get out if the gate's broken. It closes faster than I can open it. The entry phone also broke. It meant I lost all my standard hospital referrals. Plus, I couldn't get out to be medically checked. It's not a pleasant situation to be in. This was broken for 14 months. She also couldn't see friends and so on. So, um, and then the next fact and then I want to just talk about space. So space is in ELSA, which is where this model is from. We both know a sort of objective measure of space, how many rooms for the number of occupants. But there's also a question about, do people feel, what are people's perceptions? Do they feel they have enough space? The two aren't related. So, and we see this in our study. It's not just space, as in actual physical space. It's the sort of uses people want to put their space to. Sometimes the home was too big. Sometimes there was plenty of rooms, they were too small. But the same relationship here is that lack of space. If, all things being equal in terms of care needs, lack of space reduced formal care. So people with not enough space were less likely to receive formal care, even with the same care needs as somebody with more space. But on the other hand, the indirect relationship is that lack of space increased care needs, which increased the use of formal care, the total effect being more or less equal again, which is why unpacking it through this model in the interviews was so important. Next slide, thanks. Well, that's the one for unpaid care, which shows a similar but not statistically significant relationship again. So, next slide, thanks. So, looking at lack of space, so it could be insufficient bedrooms. This person, because she was in a one-bedroom flat, when she did start getting worse and having falls, we couldn't have someone to stay with her overnight because there was nowhere to stay. So this person had gone into residential care. So this was very straightforwardly lack of not enough bedrooms. Then the next slide, thanks. Size of rooms space was important. The bathroom is too small. So my mum has to have strip washers, but not a shower. Because if you're disabled on one side of your body, a care worker is not going to do any manual handling. So that means that I have to get my friend who's a physio to help me, and it'll only be every few months. So this illustrates a few things. It's a barrier to formal care use. It increases unpaid care. And there's a lot of unmet need going on here. She's only managing to have a share every few months. But on the other hand, there's another example here where there is sufficient internal space, and that meant they could have carers. It meets my needs, and it's nice because you can go round and you don't have to worry about knocking into anything. It's really big. The carers have lots of room to do it now. And the last thing I'm just going to mention is housing tenure, because how someone owns their home or doesn't is quite a critical factor on whether somebody gets care use. So privately rented, which there's a lot of increase. It's a very steep increase in privately rented in the population aged 65 and older. So this will be an increasing problem, I think. So private or council or housing association rented compared to homeowners, people living there had the earlier onset of care needs. And the greater likelihood of having care needs and the increase over time. So this again may lead to an increase in care use, but housing tenure is also a barrier to care use. So it very much affects the ability to stay in the home and the same area, thinking about community. Familiarity of the home was very important in our study to people with dementia, people with visual impairment, and also being able to stay in the home means you might be nearer unpaid or formal care. And private rented, there's a much greater difficulty in making adaptations, as the next quote on the next slide shows. So she lived in private rented, she was in her 80s. She was also very worried about asking for anything because she was worried about being evicted. because of the precarity of private rented. When the social services came around to assess me, they said, you actually need another handle in the hole to hold on to get down the kitchen steps. And you also need another one in the ensuite. We can do that for you, but you've got to give me written permission from your landlord. And I thought I'd rather not ask him for these things because, as I say, she was worried about being evicted. And this wasn't a cost to the landlord. This was going to be provided. And, you know, the precarity was also an issue and impacts quite badly on people's mental health. So just to summarize, excuse me, just to summarize in the next slide from this, and then I'll talk briefly about the kind of wider environment people live in. So housing problems in non-specialised housing increase the likelihood of having care need and a higher number and an earlier onset. It can both increase care use via increasing care need or decrease it through being a barrier or both. But there's quite a lot of significant inequalities in this. And there's a lot of cases for improving housing. It would improve older people's lives. It would reduce it would sort of optimize formal care, I think, but reducing unmet need and some of the inequalities in unmet need, reduce the pressure on carers. It is cost saving to government, different departments, as is always the problem with these things, but extremely cost saving. And of course, there's other benefits to individuals, government, and the environment of having homes that are well insulated and so on. Next slide, thanks. So I'm just going to touch briefly on a new study. So obviously where a person lives, it's not just their house and their home, and the wider environment, the community in which they live, the neighbourhood amenities. It came up quite a lot in the first study, but was sort of outside of the scope. So we've luckily got funding to return to it in this study that we're working on currently, have just really started with interviews and some of the analysis. So we're looking at the relationship of local area amenities, for want of a better word, but things like public transport, shops, community centres, and how that's linked to unmet need for care and improving access to care. So next slide. So a bit of background. So unmet need for care, as mentioned previously, an awful lot of older people in England don't get the care and support they need, and this varies hugely across the country. There is lots of evidence that local area and community is important for mental health, well-being and social isolation, but we know much less, I think, about how these sort of local amenities are related to care use, although we do know from the housing study they're really important. The policy and practice context is this big focus on neighbourhood health, health, local area, place-based, and so on and so forth, including the NHS 10-year plan. Next slide. So this is a sort of schematic, I suppose, of how we think these kind of amenities like public transport, community groups might be linked to care use, both formal and unpaid. So they might be a source of care. They might decrease the need for care. If you can get to your local shop, then you don't really need somebody to do the shopping for you or to take you there. And they might help increase access to care, for example, through advocacy, form filling, information and advice. Next slide, please. So these are the research questions. Again, it's mixed methods where, well, I'll come on to the methods in a minute. So first of all, we're looking at does unmet need cluster by geographical location? How has this changed over time? And then what aspects of local area are associated with care use and unmet need? Within area differences, because we know that just because there's some amenities in an area doesn't mean everyone can access them, because of age, because of disability, because of ethnicity, or other reasons, or financial resources. And then ultimately, how can these access to these amenities and these amenities be improved to reduce inequities in care? in care use and unmet need. Next slide, please. So we are analysing data from ELSA again, currently wave 6 to 11, and so we can look at these changes over time. And for the analysis that looks at local amenities, we're combining this with a lot of local area information from publicly available sources. So we have things on reliability of public transport and coverage, voluntary sector organisations, availability of public toilets. It's turning out to be a very rich large data set. We're doing some secondary analysis of some of the interviews from the housing project where they talked about neighbourhood or there was a particular issue. We're doing some interviews, new interviews with people living in a rural area because of all the issues around rurality. And some follow-up interviews of some people from the previous project. Another lot of interviews with Bangladeshi older people. This was a group identified in the housing project that have particularly high care needs, poor housing, and difficulty with access compared to some of the groups. And then we'll do some workshops with practitioners towards the end. So obviously what neighbourhood is varies a lot. What people think of as neighbourhood, what people think of as community varies a lot. We're having to make a kind of pragmatic decision on what we mean by that for the quantitative data, but for the qualitative, we can explore that a lot more. But as a starting point, we have two advisory groups to this project. We have one is of people aged 65 and older with care needs or carers, so sort of the general population, and another is a specific advisory group of Bangladeshi older people, which is led by a Bangladeshi community organisation who are also doing the interpreting around it. So we attend, but they lead the group. So we asked them, what does your local area neighbourhood mean to you? And for the kind of general public group, they sent these in advance of the meeting, and it could be a picture or a drawing, but the next slide shows them. So if I could have that next slide. So these are the ones we have permission to share, but you can see there's a lot of different things. And here was really nice exercise. The project team did it, and my one was used as an example of how you don't have any artistic ability to be able to do this. So, but people have actually used photos and I assume AI and images for this, but you can see there's a lot to it. For some, it's about feeling. A couple of the two on the bottom are very much about the feeling. Awful lot of them are about people. The Asian street food was both about local places to eat, but also about the diversity of the place they lived. And the one in the middle is bus and sort of market square, I think. So that's that one. And then for the Bangladeshi group, this was in person, so they've drawn theirs. So these are the next two. There was quite a lot of there's quite a lot of group work around this, so some things reappear. But again, people, feeling about being safe, people feeling about being part of the community, the mosque, food markets, and so on and so forth came up quite strongly. Next slide, thanks. And on this one, similar things, but also green spaces and transport is in this somewhere. Oh yeah, the DLR station. So it was a great exercise and helped us think about things we might discuss in the interview and all the things we might include in thinking about community and neighbourhoods. So we've started with this midway through the interviews. So looking forward to what we find out. So that's it. Thank you. Quick disclaimer. Thank you. And the last slide is just some more information. These are our papers from the study. Thank you.
Thank you very much, Nick. Really wonderful, really interesting. I'm going to open up